We present the case of a post-traumatic vertebral artery jugular venous fistula. A 30-year-old male presented to our institution 3 weeks after a self-inflicted gunshot wound to the anterior neck, complaining of persistent neck pain. At the time of the initial event, he underwent neck exploration and wound closure at an outside hospital. He was treated in a cervical collar and discharged on 81 milligrams of aspirin by mouth daily. On our initial evaluation, he was neurologically intact. CT angiography revealed a significant right vertebral artery injury with pseudoaneurysm, as well as multiple retained shrapnel fragments. Also seen was a right C3-C4 facet injury. Given the severity, we recommended he undergo angiography to better delineate his vascular injury with planned possible intervention. He was brought to the endovascular hybrid operating room. Monitored anesthesia with conscious sedation was begun. A 5 French sheath was placed in the right common femoral artery using Seldinger technique. The right vertebral artery was catheterized using a vertebral diagnostic catheter over an 035 glide wire. Angiographic runs demonstrated a severe right vertebral artery injury with a large pseudoaneurysm measuring approximately 1.5 centimeters at the C3-C4 level. There was no significant anterograde flow past the dissection, although visualization was limited due to significant fistulization from the right vertebral artery directly to the jugular circulation. We continued to perform a standard 6-vessel angiogram. There were no abnormalities in the anterior circulation. Angiographic runs of the left vertebral artery demonstrated normal anterograde flow into the posterior circulation, with retrograde filling of the right V4, V3, and V2 circulation down to the distal portion of the dissection. This is a cranial AP projection of the left vertebral artery, demonstrating good anterograde flow within the posterior circulation, along with retrograde flow down the right vertebral artery. These are left vertebral artery injections of the neck. Again, demonstrated here is the retrograde filling of the right vertebral artery, including V4, V3, and V2, down to the distal portion of the dissection. Given the severity of the right vertebral artery injury and the significant right vertebral to right jugular venous fistula, he was recommended to undergo vertebral artery sacrifice. We prepared to perform a balloon test occlusion to assess the patient's tolerability of vertebral artery sacrifice. The patient's 5 French right femoral sheath was upsized to a 6 French sheath. The left common femoral artery was accessed, and a 5 French sheath was placed. Through the left common femoral artery, the left vertebral artery was selected using a 5 French vertebral diagnostic catheter. Through the right common femoral artery, the right vertebral artery was selected using a 5 French MPC catheter. A baseline ACT was obtained, and the patient was treated with heparin accordingly throughout the rest of the procedure. A 5 mm aviator balloon was advanced into the right vertebral artery proximal to the fistula, and the balloon was inflated. Angiographic runs through the right vertebral catheter demonstrated complete occlusion of the right vertebral artery. Angiographic runs through the left vertebral catheter demonstrated retrograde flow across the vertebro-basilar junction down the right V4, V3, and V2 segments up to the distal portion of the dissection. The right posterior inferior cerebellar artery filled via the left-sided injection. After 20 minutes of balloon occlusion of the right vertebral artery, with stable monitoring on serial neurologic exam, it was felt safe to proceed with the right vertebral artery sacrifice. The neuroanesthesia team converted the procedure to laryngeal mask anesthesia, during which time all catheters were temporarily withdrawn into the aorta. Using roadmap angiography, we advanced the Phenom 027 microcatheter along with a Synchro 2 soft microwire past the dissection into the region of the V2-V3 junction. We then deployed a Medtronic microvascular plug just distal to the dissection in the standard fashion. Follow-up angiography from the left vertebral artery revealed normal anterograde filling of the left vertebral artery and posterior circulation, with retrograde filling down the right V4 segment of the vertebral artery, with normal flow out into the right posterior inferior cerebellar artery. There was no filling of the right vertebral pseudoaneurysm or the right vertebral jugular vein fistula. The Phenom 027 microcatheter was positioned in the right vertebral artery proximal to the dissection, and another Medtronic microvascular plug was deployed in standard fashion just proximal to the pseudoaneurysm. This was performed without difficulty, but the plug subsequently migrated distally into the pseudoaneurysm. Angiographic runs demonstrate persistent filling of the right pseudoaneurysm and fistula following deployment of the second microvascular plug. We then elected to perform coil embolization of the pseudoaneurysm. The Phenom 027 microcatheter was positioned within the pseudoaneurysm and multiple coils were deployed. Here we have a right vertebral artery injection in the neck with AP and lateral projections following coil embolization of the pseudoaneurysm. Post-embolization angiography demonstrated a reduction in filling of the pseudoaneurysm, but there was continued flow through the diseased portion of the vessel and through the direct vertebral artery jugular venous fistula. We then elected to deploy another Medtronic microvascular plug immediately proximal to the pseudoaneurysm, taking great care to place the plug distal to branches supplying the anterior spinal artery. Post-angiographic runs demonstrated reduced but persistent filling into the area of dissection and fistula. A subsequent coil was placed proximal to the final microvascular plug, with post-angiographic runs demonstrating complete obliteration of the right vertebral artery proximal to the dissection and pseudoaneurysm. A final angiographic run through the left vertebral artery demonstrated normal anterograde filling through the left vertebral artery and posterior circulation, with retrograde filling of the distal right vertebral artery and normal flow into the bilateral posterior inferior cerebellar arteries. The catheters were withdrawn and the bilateral groin arteriotomy sites were closed with a 6 French angioseal in standard fashion. Post-embolization, the patient remained neurologically intact. He was seen in clinic for follow-up at 3 months. He reported no neck pain and had full range of motion. A 6-month follow-up angiogram demonstrated stable embolization of the right vertebral artery without evidence of pseudoaneurysm or recurrent or residual arteriovenous fistula. The right interspinal artery was observed to fill via the right vertebral artery. Left vertebral artery injections demonstrated appropriate filling of the left vertebral artery and posterior circulation, with retrograde filling of the right vertebral artery with patent posterior inferior cerebellar arteries bilaterally.